Okay. Can everyone hear me okay?
Yes.
Sorry. I know I'm from behind the curtain a little bit. I'm sorry I can't make it in person today, but I just wanted to thank everyone for letting me talk to you this afternoon. I'm actually at another meeting out of state, so not quite at the point where I can clone myself or teleport. So I appreciate you letting me talk to you over Zoom today. So anyway, my name's Billy Kennedy. I'm a radiation oncologist here at Barrow. And this afternoon, I'm going to be talking about radiation therapy for acromegaly. Now, perhaps some people in the audience have had radiation therapy of some form or another in the past, or have a loved one who's gone through it, or maybe some of you or your loved ones may need to go through it in the future. Just want to learn a little bit more about what we do. And so either way, I'm hoping this talk this afternoon will be educational. So today I'll outline my talk by going through some of the most important questions asked by patients in my clinic. And by doing this, hopefully you can get a better understanding of what radiation therapy is, what the process entails, learning the differences between some of the types of radiation therapy we use, and when I might see a patient with acromegaly in my office to discuss all these, how well we can expect it to work, and then some of the side effects that we look out for. So first off, what is radiation? So I'm only going to nerd out for a couple minutes, I promise, but I just want to give a little. It's a little bit nebulous, so I just want to kind of explain a little bit more. So radiation is the transmission of energy in the form of waves or particles. So waves being when you hear about photon-based or X-ray types of therapy, particles being proton therapy. And just like waves of water travel in the ocean, waves of energy in the form of radiation travel around us in space, and it's all around us. The type of radiation only depends on the energy of the waves. So very low energy radiation, kind of at this side of the spectrum on the left, those are radio waves, and that's how we can listen to music on or sports on the radio. And as we increase in energy and shorten the wavelength along the spectrum, then there's microwaves. That's what we use to heat up food. Then infrared radiation, probably the most common source of infrared radiation is the sun, and that's the reason our skin feels hot when we're in the sun, because infrared radiation carries heat from the sun to our skin. Then's visible light, and that's what allows us to see with our eyes. It's the reason you can see this PowerPoint on the screen today. That's a form of radiation. As the waves get smaller, they can start interacting with the atoms and molecules of our body. And as they have the ability to do this, they're called ionizing radiation. So that includes ultraviolet radiation. Besides being a source of infrared light and visible light, the sun is also a source of ultraviolet radiation. That's why our skin can burn in the sun if we're out too long and don't put on sunscreen. We have X-ray radiation, such as when you go to the dentist's office or get a chest X-ray, but also what we use in radiation therapy most of the time to treat tumors. And I'll discuss more about these. And then finally, we have the gamma ray, which is the highest frequency form of radiation. We also use these to treat tumors. And so of note, even though people can use X-rays and gamma rays for medical purposes like myself or diagnostic radiologists, these occur naturally in nature as well. They can come from outer space to Earth. They also naturally arise in a lot of different materials in even foods like potassium in bananas or in the soil. And so let's see. So ionizing radiation is used in the medical field in a few ways. In diagnostic radiology, radiation, namely X-rays, to visualize inside the body, so we can help diagnose different conditions. And then in radiation therapy, a radiation oncologist, such as myself, uses therapeutic radiation to treat tumors, like pituitary tumors. So for instance, chest X-rays and CT scans are a few commonly used imaging studies in diagnostic radiology. These allow the radiologist to visualize the lungs, the heart, the ribs, etc. And then on the other hand, I know we're talking about pituitary tumors today, but this is another form when we're treating a lung tumor. And so we can use higher energy and more focused x-rays to target a tumor that may be seen by a radiologist. And I'll talk about these things in a little bit more detail. And I promise just one or two more slides about the nerd stuff, but how does it even work? So x-rays, because they are a form of ionizing radiation, can interact with atoms and molecules. Our bodies are mostly made up of water molecules. So when we get x-rays, the x-rays can interact with our water molecules and actually break them apart. And when a water molecule is broken apart by an x-ray, it forms something called a free radical. And these are highly reactive molecules that can interact with DNA and cause it to break. And now, because we're surrounded by radiation by merely living on planet Earth, and our bodies see radiation from the sun and from materials in the ground, our bodies have pretty good mechanisms to fix these DNA breaks and go on living a normal cell life afterwards. But most tumor cells are not healthy cells. They're not as good at fixing DNA. So when their DNA is broken, they often eventually die. And so it's this different response to DNA breaking that allows healthy cells to live and tumor cells to die. Of course, this is an oversimplification, and there's different pathways, resistant pathways around that, even in tumor cells, but that's just a general concept. And that's why, in general, we use X-rays to treat tumors. In addition to breaking DNA, there are two other major ways radiation can affect tumors, and these include causing inflammation to help the immune system better recognize and kill off tumors. And then, in addition, radiation can damage a tumor's blood supply and starve the tumor of nutrients. And that's actually one of the more indirect mechanisms of how we think radiation therapy works for different types of pituitary tumors, like in acromegaly. So last but not least, not that we use chemotherapy in pituitary tumors rarely at all, but we also, sometimes you hear about chemotherapy, they often get confused with radiation. And so a common question I get is, what's the difference between these two? Chemotherapies are often chemicals that travel in the blood and are either given by an infusion intravenously or by mouth. And so because it travels in the blood, it goes to all parts of the body. Radiation, on the other hand, is more focused, and we really kind of direct them at one part of the body. So now that we've talked about kind of the, hopefully not in too much detail about how radiation works, let's talk about what's the process of getting radiation therapy. So it's a multi-step process, and I've listed the steps here, and I'll go through each of these. The first step is just to meet with a radiation oncologist for a new patient visit. And so here at Barrow, that would be either Dr. Barani, Dr. Kraus, or me. And during the visit, we discuss with you and your family whether radiation might help you, what are the potential risks and benefits. We'll discuss the goals of treatment, any side effects that could arise. And so depending on the clinical situation, goals of treatment can include cure or remission, and or to provide comfort or treat symptoms. Radiation treatments in general are determined by the clinical studies that we've conducted over many years, and we use the data and evidence to help guide our decisions and have these discussions. And that's kind of what we call evidence-based medicine. We can often pair it with other treatments, such as different medications in acromegaly or in conjunction with surgery. Sometimes we only use one or two of these types of treatments, but in the case of acromegaly, patients almost always have received at least one surgery and a couple lines of medications before they consider radiation therapy. So the next step is the simulation session, the planning session, basically. So during this, our team will position a patient's body to simulate the position they'll be in during the treatment. So on the left, for instance, would be a very typical, sometimes we'll cut out holes in the eyes or the mouth to help with claustrophobia, which is a really common thing that patients deal with. And so we do the simulation before we actually do any radiation treatments to try and kind of iron these things out and make this as smooth a process as it can be. And so on the left would be a very, for someone with a patient with acromegaly undergoing a radiation treatment, we'd make a mask similar to this, several days before the actual treatments mostly. and then this takes about 20-30 minutes or so. It's custom made, and then they go home. This would be an example of maybe someone who's getting a spine treatment. But again, we use radiation, throughout the body to treat all sorts of different things. And so there's different devices that we use to keep people on the exact same spot during the treatment. And so that's kind of the simulation. It's kind of like the dry run. And so the next part of the process is the radiation planning. So after the patient's gone home, after that, usually about 20 to 30 minute planning session, then that's where me and my team really work hard in the background. A whole team of professionals takes part of the radiation planning, including myself. We have physicists, we have dosimetrists. We've got a whole host of folks kind of working on this in the background. That can take 5 to 10 business days because there are a lot of quality assurance and safety checks that we have to do in the background to make sure we're delivering the best plan possible. So during this process, so this is not a pituitary tumor, this is what we call a glioma, a brainstem glioma. But during this process, basically, I use a very expensive version of Microsoft Paint, kind of draw out the tumor, and then basically that's only one part of it. We also draw out all the normal parts of the brain nearby, including the eyes, the optic nerves, the optic chiasm, the normal brain, the hippocampi back here. Those are important for controlling short-term memory. There's a long list of normal parts of the brain, just using the brain as an example, that we draw out and try and account for and avoid. And so this is a very timely but very important process that we do. And so a very common question that I get is, well, how does radiation destroy the tumor or affect a tumor but not hurt the surrounding tissues and organs? And so this is actually a pituitary. This is actually a pituitary treatment plan. You can see. I'll show you kind of better plans from patients that I've actually treated with acromegaly in my clinic. But basically, you can see here. How does this is really a pretty small area. There's a lot of important stuff nearby. There's a very minimal amount of dose to the normal brain. It's hard for you guys to appreciate on this picture, but how does that actually work? And so here's an analogy I like to use. Multiple spotlights above a dark stage, they can make an actor bright, but the rest of the stage is pretty dark. Just like this, the radiation beams all shine on the tumor such that the tumor gets a lot of radiation, but the surrounding brain tissue gets very little radiation. Comes from a lot of different angles, very dim lights individually, but when they all meet in the center, it shines pretty bright. And so here's just another example with the spine. The tumor, which here appears pretty red, is getting much more radiation than the surrounding tissues. The blue streaks are some of the radiation beams. This is actually kind of an older technique called IMRT, but the radiation in the blue streaks is still extremely low compared to the radiation in the red area. So the radiation still has to come from the outside in, of course, but by increasing the number of beams and the different angles, we can best try and minimize collateral damage, so to speak. That's probably the best way to think about this. Just a little bit in the background. So using computer software, we're able to calculate the exact doses of radiation to tumors and to the normal organs to ensure we've created the safest plan possible. And sometimes we have to go through many, many iterations of this in the background. And it's only after all these safety checks are met that we'd actually start the radiation plan. So that's why it takes some time between doing the actual planning and delivery of treatment. It's really not an exception, but one of the things that we use quite frequently, especially in acromegaly, is something called gamma knife. I won't bog you down with too much of the details of why the planning is shorter, but it's really it's the one where we can do the planning session and the treatment usually the same day. But it still goes through all these checks. It's just anyway. There's at least some amount of time between the actual between the simulation actually delivering the radiation to make sure all these things are met. And so the next part of the process are the radiation treatments themselves. Now here at Barrow, we're fortunate to have quite a few different ways to deliver radiation therapy. And the machines we have for this, at least in my clinic, include the gamma knife, the cyber knife, and the TrueBeam. And they all look somewhat similar from here, but really each is a specialized tool for a different task. And for many parts of the body, they can be adequately treated with one type of machine, but when we're trying to deliver precise radiation to much more delicate areas like the brain or the spine, it's really important to have the best tools at your disposal. Probably the other type of radiation therapy that's given in pituitary tumors in general, including acromegaly, is something called proton therapy. We don't have that. At my prior institution, I was at WashU before. We did treat some patients with proton therapy. We do have it at Mayo Clinic has it up in Phoenix, so we do have that option. And sometimes that's an appropriate tool. I'll go into that in a little bit more detail as well, because that is another thing that you may hear about. So sometimes you'll hear about something called stereotactic radiosurgery, or SRS. That's basically when we give a higher dose of radiation per day over a relatively short period of time in 1 to 5 days. Although the individual day or days are typically longer. Sometimes they're 45 minutes, sometimes they're a couple hours. And although the machines that deliver SRS often have knife in the name, including CyberKnife and Gamma Knife, and it's called radiosurgery, there are no incisions, and this is done all in the clinic, not in the operating room. They're essentially marketing terms. And SRS is different from conventionally fractionated radiation, sometimes called IMRT or VMAT, in that conventional fractionation is when we deliver a smaller dose of radiation each day over several weeks, usually in the setting of acromegaly, about anywhere from 28 to about 33 treatments or so. Usually, if you're in my clinic, about 30 treatments would be what we typically use if we need to use kind of spread out the dose. In addition, there are older, mostly outdated techniques, 2D and 3D conformal radiation. And I'll go into the decision-making process for one or the other soon. The next part of the process are the weekly on-treatment visits. And during these weekly visits, we talk about how you're feeling during radiation treatment and any help with any side effects, and just answering any questions that kind of come up that weren't answered initially. And some common side effects during radiation for pituitary treatments, they include some temporary fatigue, sometimes headaches, some nausea, and then less commonly, some patients can get an odd smell sensation, kind of like they'll describe it to me as like an ozone sensation or like a burnt sensation, which is pretty uncommon, but particularly it's more common when we're treating the pituitary, just because we're treating an area right near the part of the brain that processes smell, called the olfactory nerves or the olfactory center. And sometimes people can experience something, it's like a flashing blue light during the radiation treatment. And that's actually called Cherenkov radiation. I won't nerd out again. I've already done it once, but they only occur when the radiation beam is on typically, and they don't necessarily predict for damage to the actual senses, vision or smell, but they're things that patients describe to me on occasion, specifically when we're treating a patient with any sort of pituitary tumor, acromegaly included. And then after the radiation's delivered, we talk about follow-up. And so an important part of follow-up imaging, this is images of different types of brain tumors that I treat, for instance, but just to show different types of brain MRIs that I look at. Obviously, I look at much more tests and imaging than a brain MRI. It's not the only thing that's important to me, but just to have an example here. It's important to note that radiation works slowly, especially for slower growing tumors like pituitary adenomas. So sometimes the tumor looks the same for a few months, even sometimes a year or two after the radiation. It doesn't necessarily look smaller much at all initially. And initially, that's okay. In fact, sometimes the tumor never looks smaller and it just stays about the same size. Sometimes that's the best that we can expect from radiation for pituitary tumors, is just to prevent further tumor growth, try and protect it from pushing on those adjacent normal nearby structures, namely the optic nerves, the optic chiasm, like Dr. Golnick talked about. So usually these changes are subtle. That's one of the reasons why we space out MRIs usually over several months apart or even a year apart, because it's not that we're losing some window of opportunity if we were to see some negative change here. It's just that sometimes the changes that we see after, let's say, radiation therapy are very gradual. And so doing them sooner, that it may be just exposing you to more imaging that can be expensive, and it's a time cost as well. And so that usually it takes that amount of time. So that 6 months to a year is usually a pretty good balance. And so, besides imaging, you'll also be seeing the doctors that treated you, myself, an endocrinologist, an neuro-ophthalmologist, a neurosurgeon. And, the most important thing to remember is that this is a big team and each is specialized in a certain aspect of your care, but we're all working together to care for the patients. And so I'm not only looking at brain MRIs, but also looking at hormone levels, the visual field testing that Dr. Golnick might send me. And then we all know that these are only a few parts of the overall puzzle, as evidenced by all the other specialists talking at this conference. So, it's tests, imaging, that's only one piece of the puzzle. Your day-to-day, your quality of life is also incredibly important to me. And so those are the things that we talk about at follow-up as well. And so just to recap, before we dive a little more specifically into some of the data for acromegaly, just to give you a little bit more context, radiation therapy are high energy light waves that damage tumor cells. Many brain and spine tumors benefit from radiation therapy, often in combination with surgery and or medications. Radiation planning, it's an involved, resource-intensive process. It's the stuff we do behind the scenes to ensure safety and effectiveness as best as we can control. Each type of machine is best for different clinical scenarios. It's not a one-size-fits-all approach. And regular imaging and office visits are an important part of follow-up after radiation therapy. And so basically, so now that I've given an overview of what radiation is and the process behind it, I want to finish the talk with going over some important issues specific to patients with pituitary tumors, especially acromegaly. Now, I very commonly care for patients with pituitary adenomas. I much more commonly treat patients with pituitary tumors that don't produce different hormones, like growth hormone for acromegaly. It's most often in patients with an incompletely removed pituitary tumor, or one that isn't safe to completely remove surgically. And this is because radiation is a very effective tool in preventing increases in size of pituitary tumors. They don't cause them to melt away overnight. Of course not. Sometimes they just kind of stabilize things for years. And radiation therapy is still used in patients with secreting or what we call functional pituitary tumors. This is in the case of acromegaly. Some of you may have heard of something called Cushing's disease. That's a pituitary tumor that secretes another type of hormone called ACTH, and prolactinomas. But less often radiation is used due to the fact that most of the time, not always, medications in place of or before or after a surgery work well enough, and radiation therapy often takes a long time to lower hormone levels, and it doesn't always do so. It doesn't, in general, do so quite as effectively as it does in preventing just physical growth of a tumor. So on either side, just to not go too far on this, Dr. Golnick explained this really well already, but on either side of the pituitary gland is a part of the skull called the cavernous sinus that's here and here. It's an area that's difficult for a surgeon, even the best ones, to completely remove a pituitary tumor if it grows into this area, because important nerves and blood vessels course through the cavernous sinus. The two little red circles here, those are the carotid arteries. So that supplies the most, not all, but a lot of the blood to your brain. And then these little kind of more pale areas on either side are different cranial nerves. They're not the nerves that control your actual vision itself. That's the optic nerve, or the optic chiasm, that sits above the pituitary. But they control basically the ability to open the eye and move the eye. So things like double vision, blurred vision, those kinds of things can happen. And so they can often remove and go into the cavernous sinus only to a certain extent. And because if it becomes to a point where it's getting too close to that blood vessel or those nerves, then instead of aggressively scraping out a tumor and potentially causing some permanent damage there surgically, sometimes they'll leave a small amount behind. You don't necessarily need to jump in with radiation right away. Sometimes you may never need radiation therapy in that situation. That's the main area that we often use radiation to kind of target a bit more safely than kind of trying to scoop it out with the surgery. I know it's a generalization, but just to give a little more context, because these are some of the things that you might discuss with your radiation oncologist clinic. So now on to acromegaly specifically. So just to get an idea when radiation therapy is thought about in managing acromegaly, here's just a recent review article from a couple years ago. And you can see this very long chart, and you don't see radiation anywhere here. You don't see radiation anywhere around here. We're kind of right down here, which is okay. It's not a critique. It's just knowing that often multiple surgeries and multiple medications, including cabergolines, somatostatin receptor ligands, octreotide or lanreotide, azareotide or pegvisomant, they're all considered well before radiotherapy in managing acromegaly. And so this is kind of the short answer. When surgery or medications don't completely work, that's when we think about radiation. So it's not an exact rule. Everyone's situation can be a little bit different. Sometimes patients aren't able to undergo surgery due to a variety of reasons. Maybe they have other health issues, or the medications used to control acromegaly, it's not that they don't work, but maybe they have some undue side effects preventing someone from continuing to take them. These are often also, maybe they're not available due to where you live or cost. And so to reiterate the overall goals of radiation acromegaly, the main things I hope to accomplish when caring for patients are first to prevent tumor growth into the important areas next to the pituitary gland, namely the optic nerves, that's right above the pituitary gland that controls vision, and the cavernous sinuses on either side that have all those important nerves and blood vessels. And then, goal number 2 is to reduce excessive growth hormone levels produced by these tumors, which will hopefully prevent worsening of many of the downstream effects of this. And then importantly, to try and achieve those 2 goals without causing undue side effects. Sometimes that's a little bit easier said than done. So to give a bit of a history lesson and some context, radiation therapy has been used since the early to mid 1900s to try and treat acromegaly. Now, many, many years ago, we as a medical community didn't have the imaging to accurately see small tumors that are often the size of a pea or smaller, not always the case, but many times, nor the technology to deliver very precise radiation therapy to small tumors that are in a really important part of the brain with a lot of important stuff nearby. So many years ago, the main goal was just to not miss the tumor. And 2D radiation therapy, which was how radiation was delivered for decades until really the late 80s or early 90s, that was done by a radiation oncologist, probably with a lot more gray hairs than me, drawing the outer borders of one big radiation beam coming from the left with a wax pencil on an X-ray, and then doing the same for a second big radiation beam coming from the right, taking some measurements, getting the patient lined up as best they can, and turning the machine on. Given the huge uncertainty with this approach, often the entire skull base was targeted, and 2 big beams delivered a full dose to all of the adjacent normal pituitary tissue, the carotid arteries, the cranial nerves, and parts of the normal brain nearby that control short-term memory, the hippocampi. And so this is like an example, obviously on a modern treatment or a more modern treatment planning system, but showing kind of like the older 2D treatments that were used for many, many years. And a lot of the original safety and effectiveness data of radiation are based off of. In the center and right are examples of 3D conformal radiation, which I would still argue is outdated today, but that's in the center and right. And those were mainly used once we had computers, CT scans, and brain MRIs, more available in the 1990s and even early 2000s, where we could diffuse the really high doses, the red basically on these, by adding in a couple more beams from different angles. There's a little bit less of there was a little bit more precision, so we didn't need to treat with such large margins. There was still quite a bit of entry and exit doses, as you can see here, but that was definitely a big improvement from 2D radiation. And this is important to understand because, again, that's where much of the original experience comes from. But fortunately, we've continued to make huge improvements in the precision of radiation therapy over the past 20 years or so. volumetric modulated arc therapy, or VMAT, delivers X-rays from a series of 2 to 3 arcs to a much more tightly shape the radiation dose and minimize dose to adjacent normal nearby structures, given over 5 to 6 weeks typically. SRS, like we talked about before, with either Gamma Knife or CyberKnife, can be given very precisely over 1 to 5 days. Gamma Knife especially has been around for longer, but it has improved. The kind of general concept has remained the same for over 20 years, but it has become much more precise over the time frame now. And as some of you who know a little bit more about the background of this, you may hear about Gamma Knife and hearing about people needing to put these metal frames kind of placed with screws on their head and all this stuff. We don't have to do that anymore. We use those plastic masks to treat. It's much more comfortable for a patient. It's not perfect, but it's much more comfortable than some of the kind of older ways to even deliver Gamma Knife. So there have been a lot of changes over the past 20 years or so. Proton therapy is yet another form of radiation therapy that has a higher entry dose than X-ray based treatments when you're looking at just one beam, but has a minimal amount of exit dose. So there's a theoretically reduced normal tissue exposure and side effects. Although that's unclear if there's a huge benefit over the more state-of-the-art photon-based radiosurgery in VMAT. But so basically the thought is that most radiation oncologists don't think that proton therapy, for instance, is any more effective in terms of hormone control or preventing tumor growth. But there is some thought that maybe there is some lower dose to the nearby carotid arteries or the hippocampi that control short-term memory, potentially a lower risk of the extremely rare but potentially life-threatening radiation-induced cancer. These studies are often compared to some of the older techniques with prior X-rays, because actually proton therapy has been around since the 70s or 80s. It has fortunately become much more available throughout the country. There's about 30 proton centers in the US now. And so there aren't very good head-to-head studies with the most state-of-the-art X-ray, more commonly available photon-based treatments and proton therapy. But basically, the right answer here is that there's a lot of different there's a handful of newer technologies that are night and day more efficient, more precise, and safer than some of these kind of older, pretty antiquated techniques here. And so here's an example of an SRS plan that's delivered with Gamma Knife. This is just a Gamma Knife plan from my clinic. And as you can see, there's a pretty sharp dose fall off that's indicated of the intermediate and high radiation dose. It's indicated by the yellow and green circles around the pituitary tumor we're treating, outlined in blue. That kind of darker gray is what a pituitary tumor looks like on a brain MRI, kind of looking this way. As you can see, there's the eyeballs, there's the nose. And this is just to kind of compare it, kind of apples to oranges here, comparing it to kind of these older techniques to kind of some of the newer technology that we have here. Of course, there's still some level of entry and exit dose since the radiation's being delivered from outside the patient, but it's much, much less than techniques our field used for decades, even into the early 2000s. And so, I use the Gamma Knife plan for just one example of a modern technique and a plan that I deliver here at Barrow. However, in reality, there are multiple good technologies available, and each center often has slightly different tools at their disposal. Probably the biggest difference apparent to patients is the number of treatments. So how does a radiation oncologist decide whether the treatment is completed in just one day, as in some Gamma Knife treatments, versus 6 weeks of daily treatment, Monday through Friday, over 30 treatments? This is a huge difference to patients, and the time and cost involved with coming to and from the clinic is really important to me too. At least in my mind, if I can safely deliver all of the dose in 1 to 5 days using radiosurgery with either Gamma Knife or CyberKnife, I prefer this approach given the convenience for the patient as well, without compromising quality or safety. However, this is really most safely used in patients with pretty small tumors that aren't pressing up against the optic nerves. So usually we'd use Gamma Knife in a relatively small tumor that's not affecting a patient's vision, but it's having persistently high growth hormone levels that aren't being controlled with multiple rounds of surgery multiple courses of medications. If a tumor is very large or too close to these nerves, then the right thing to do in my mind, since first do no harm, is to break up the treatments over those 6 weeks, which may lower the risk of radiation-induced optic nerve injury months to years after the treatment, because it's giving a little bit more of a gentle punch each day instead of delivering all the dose in like 1 to 5 days. So overall, how effective is radiation therapy in acromegaly? Again, the oldest 2D and 3D techniques have many decades of follow-up, but even gamma knife, cyberknife, VMAT, proton therapy have well over a decade of follow-up. For every 10 patients with acromegaly that I treat, I can prevent 9 of them from having any further tumor growth. So it works well, but again, like all the therapies that we're talking about, nothing is perfect, but it's a pretty good tool. However, it is still an important tool to provide hormone control, but it doesn't work quite as well. It works in maybe 7 out of 10 patients at best, especially when we're using more strict definitions of hormone control using IGF-1 tests instead of the older when they would just measure growth hormone levels, just that alone. And a big reason for this is because we're really only using radiation in patients where surgery or medications haven't worked very well. So we know that these tumors are a little bit more resistant to those first and second line therapies. And so we're kind of selecting out the kind of tougher ones to treat in the first place. And then the main thing to remember is that the full effects of radiation therapy, they often take several years to kick in, with some studies saying it takes 7 to 10 years to have the full positive effects of radiation in terms of hormone control. So this is a very long, it takes a long and sometimes really, in my mind, too long. But we do have it as an option, especially when other things haven't worked. And so furthermore, some people are under the impression that SRS with gamma knife or cyberknife are more effective than the more spread out 5 to 6 week treatments we often do with the up to state of the art photon therapy or even proton therapy. However, I don't necessarily agree with this notion, even though I do prefer SRS if it can be done safely. And this is because of something in medical research we call selection bias. That is, again, patients treated with SRS in that 1 to 5 day course, they're much more frequently to have smaller tumors than patients with the longer courses of radiation. Smaller tumors may respond better and more quickly to radiation, regardless of what technique is used. And this can cause some people to maybe incorrectly conclude that SRS is more effective than conventional radiation when it's in fact just that smaller tumors are less stubborn than bigger ones. And this is an open area of debate in the radiation oncology community, actually. Some of this comes from one very small study that showed in 30 patients with acromegaly treated with either radiosurgery or conventionally fractionated radiation, although the same proportion of patients ultimately achieved hormone control with either radiation technique. So ultimately, effectiveness rates were nearly identical. This happened 2 to 3 years earlier after delivering SRS than the longer course of radiation. And again, even in that study, patients treated with SRS did in fact have smaller tumors. There haven't been a lot of good quality studies on this issue since then. It's some things that we're kind of looking into, or I'm looking into, but it takes time to kind of collect these data. And none of this is to say that we shouldn't use SRS. It's usually what I prefer to use, but it's more to just try and reinforce that if a radiation oncologist is recommending a more drawn out course of treatment, they're often doing so to try and maximize safety, not offer some less effective, more inconvenient type of treatment. It's a conversation that I do have to have once in a while with patients. So hopefully this just gives a bit more context. And then just be almost done here with kind of the different issues that we face here. Another thing to consider is that if radiation in any form is planned, most patients are instructed to hold any IGF-1 lowering medications if possible for 1 to 2 months prior to starting radiation therapy of any form. The thought is that stopping the meds before beginning radiation makes tumor cells more sensitive to the effects of radiation therapy. And although there are some proposed mechanisms for why this is the case, the reality is that no one really knows for sure. So although there are some conflicting results out there with some studies showing similar hormone control rates regardless of whether you stop medications or not, most of the time, pretty much all the time, if we're able to, is still typically instruct patients to hold their medications temporarily, given the largest, most recent study on this issue shows that long-term remission rates are slightly higher in patients who hold medications prior to RT. So now regarding the potential side effects of radiation, Again, with older techniques, more normal tissue had to be exposed to treat the tumor as best they could back then, which led to more side effects. It isn't to say that proton therapy, gamma knife, cyber knife, VMAT, these modern techniques are some magic bullet without any toxicity, but the frequency of these effects are typically lower with newer technology in general, fortunately. The most common side effect from radiation therapy that we still deal with to this day is panhypopituitarism, which can be a serious issue, given that we're treating a tumor that is either next to the normal pituitary gland or replacing the normal pituitary gland. Some people come to me and they already have deficits or poor pituitary function before we even do radiation therapy, either from the tumor, from multiple prior surgeries, or a combination of both. And so there is some degree of normal pituitary gland that gets exposed to radiation. The hypopituitarism from radiation occurs gradually, often at least 1 to 2 years after radiation, with up to half of patients experiencing some degree of this 5 years after radiation. So it's a very common issue. These rates are more like 20 to 30% after SRS or proton therapy. But it's still a very significant issue. So it's still something that we screen, and that's why your endocrinologist doesn't just check for growth hormone. It's not the only thing we look at. We look at that whole pituitary panel, even in patients who have not undergone radiation therapy at all, because it is something we have to look out for. Radiation can also affect vision, even though we're trying to do a treatment to preserve vision. Many years ago, these rates were up to about 5% of patients, so not a benign thing. But fortunately, this is about 1 to 2% at most after radiation nowadays with more careful planning. Finally, with the older techniques exposing nearby blood vessels, the carotid arteries, to high doses of radiation, there's an increased risk of strokes years after 2D and 3D conformal radiation therapy, some short-term memory loss potentially, and even an extremely low risk, about 1 in 1,000 patients developing a radiation-induced brain tumor. However, most recent studies evaluating tens of thousands of patients treated with things like SRS or even proton therapy, especially, have failed to see those kind of same increased risks of stroke, short-term memory loss, or radiation-induced cancers. Although these studies are hard to do, so I still bring them up as theoretical risks even now. And then another thing to consider is that while we are still very selective in the use of radiation therapy for patients with acromegaly, and rightfully so, given all the things that I've talked about to this point, SRS, for instance, represents a very relatively cost-effective option compared to some of the commonly used medications that patients often take for many years, is supported by cost-effectiveness analyses. So this isn't to put any of those options in a negative light, but rather to remember that value-based care and financial toxicity are real things that we can't ignore either. So in conclusion, radiation therapy is, in general, they're high energy light waves that damage tumor cells. Radiation therapy is used in acromegaly, often if surgery and medications haven't worked, but it's not always a one-size-fits-all approach. Multiple different radiation techniques are available, all have their own pros and cons. Radiation therapy is very good at preventing tumor growth and pretty good so-so at IGF-1 control. Hypopituitarism is the most common side effect we see after radiation, even with newer techniques. It's still quite common. Optic neuropathy is fortunately quite rare after radiation therapy, but it is still an issue and something we screen for afterwards. And then radiation therapy in general is a relatively cost-effective option in comparison to some of the other therapies available for acromegaly. So again, I just want to thank the acromegaly community for inviting me to speak this afternoon. Sorry I can't be here in person, but again, I just very much appreciate it. And most of all, I want to thank you all for your time, for being here, and for allowing us to care for you and your loved ones. It's truly an honor and privilege. So thank you. All right. I can't hear you guys if you do have any sort of questions or anything like that. Also, I think we have some questions through the live chat, so maybe I'll answer that one first. Will you be speaking about proton therapy and advancement technology of the last 2 years? Hopefully I answered some of those things. I know with 45 minutes, I can't get a super deep dive into proton therapy, but it's actually my first research project as a med student was looking at proton therapy in pituitary tumors. So it's something that I've been looking at for a while. And that was many years ago now, but hopefully that answered. So if anyone wants to go through the chat, or hopefully I can hear you from the room, maybe we can start.
Go ahead.
Yes, doctor, thank you so much. That was a wonderful discussion. So with a tumor 5.6 millimeters in diameter, invasive into the cavernous sinuses and about the pituitary, pretty diffusely located, does it seem like proton therapy might be the best option?
I really apologize. It's very difficult. Can someone like reread that? I can't. The audio quality is not good.
Yeah, can you hear me now, doctor?
I can hear you better. Yeah.
Okay, I'm asking about a tumor that's 5.6 centimeters in diameter that was diagnosed already invading the cavernous sinuses and was heading upward. Has undergone 2 surgeries and is relatively well controlled on medication. If we were to decide to do radiation therapy for that, does it sound like proton beam would be the best option?
Not necessarily. It depends. So is it 5.6 centimeters after 2 surgeries? That seemed
No, that was the original size. That,
okay.
but it hasn't, to be honest, it hasn't really, decreased all that much with treatment.
So if the tumor hasn't increased at all in size, if there's maybe some small residual tumor, they're monitoring the cavernous sinus. So that plus, if patients are well controlled on any GH inhibitors, somatostatin analog, whatever combination of medications that they're on, and they're tolerating it well. My personal bias, there's a little bit of gray area, is to avoid radiation therapy, particularly because of the high risk of panhypopituitarism. I do monitor that. That's just my own bias. Of course, that's with careful brain MRIs, usually once a year, depending on how far out the surgery was, 6 months to a year, visual fields testing, IGF-1 levels, and if all those things are controlled well, then I typically would withhold radiation therapy for maybe the point that those things stop working, or if they do at all, or there seems to be any sort of tumor growth on an MRI, anything like that. So those are the different, those are kind of the different kind of trigger points. But I typically would hold off on radiation therapy for the time being, because of the risk of hypopituitarism and the downstream effects that it can cause.
Actually, panhypopituitarism was present at the time of diagnosis, so that's not really a concern. The patient is receiving supplementation already.
Yep. So of course, but I still, so that's a good, so yeah, right. Because panhypopituitarism is still something that's commonly even at diagnosis, especially with a tumor that size. It's an open discussion. I still typically would reserve it. If in someone who's had 2 prior surgeries and everything else is controlled, we would usually bring in radiation if there was any evidence that IGF-1 was rising or there's any growth on an MRI. So I just, it's definitely an option. If there's a small amount of residual tumor that's far away from the optics, proton therapy is very appropriate, and that's usually given over about 5.5 to 6 weeks or so, give or take. It's usually, there's a few different ways to deliver it. So that is absolutely a reasonable option. If it's small though, and away from the optics, things like Gamma Knife or Cyber Knife, any SRS is going to be just equally safe and effective, at least from all the data that I have. So either are very good options. It really depends on what you have in your community. And so at least from that information, hopefully that answers things. Yeah.
Thank you.
Thank you.
Yeah. And then,
Thank you, everybody.
of course, you bet.
You dropped us on the way in.
Yep. And then Dr. Castellan Vargas, I'll type in the answer too. So.
So far from him.
Yep, I will.
That's a good point.
Awesome. Thank you, Dr. Kennedy.
Thank you.
Thank you, Dr. Kennedy.
You bet.